In this lecture, we're going to be discussing the lateral collateral ligament.
The goals for this lecture are for you to be able to describe what the LCL is, describe the clinical presentation of LCL injuries, in addition to determining potential concomitant injuries that can occur with LCL injuries, and describe the intervention strategies used to treat LCL injuries. The lateral collateral ligament is the primary varus stabilizer of the knee. It is extracapsular and rare to have an isolated LCL injury. Usually if you injure your LCL, there's going to be other injuries as well. The LCL runs from the lateral epicondyle of the femur to the head of the fibula. It does not attach to the meniscus. Remember, that's different from the MCL where you have that medial meniscus attachment. With the LCL, there's no meniscus attachment. The structure of the LCL is discrete and cord-like, and it has a width of about 4 to 5 millimeters, so that's about half a centimeter in width. The function of the LCL primarily is to resist varus force, but it also resists knee extension, prevents internal rotation of the leg with the knee extended, reinforces the lateral capsule, and also reinforces the posterior lateral capsule. Remember, this is extracapsular, so it's not within the capsule itself, but having that external support will help provide that reinforcement to the capsule. The LCL is part of the posterior lateral corner. The other structures within the posterior lateral corner are the popliteus tendon and the popliteofibular ligament. Those three structures combined makes this posterior lateral corner, and the main role of this is to resist posterior lateral rotation of the tibia relative to the femur, along with helping resist against those varus forces. Oftentimes, this does not get injured in isolation. Only 28% of PLC injuries occur in isolation. Most commonly, it's associated with an ACL or PCL injury, and it's a pretty major injury where you see a lot of different impairments associated with it. Oftentimes, it's attributed to some sort of trauma with a very distinct mechanism of injury. It can happen non-contact, but the vast majority of them will happen with some sort of contact. LCL injuries occur in about 7.9% of high school athletes. Lundblad et al. Showed that men's professional soccer teams can expect about one LCL injury every 3 years on their team. It's often injured with other structures, including the rest of the posterior lateral corner, the ACL and the PCL. Trauma-induced injury most of the time with contact sports or motor vehicle accidents. The mechanism of an LCL injury is typically a direct blow to the anterior medial knee. It can also occur with hyperextension, non-contact varus stress, and potentially external rotation. Remember, the PLC is responsible for resisting the posterior lateral rotation of the tibia, which is relatively synonymous with external rotation of the tibia. So if there's too much external rotation at that joint, it could potentially injure this LCL. We'll use the same classification system as we did for the MCL. Grade 1 is minimal tearing, might be tender to palpation, a little bit of discomfort in that region. Grade 2 is partial tearing of the LCL, so more fibers than the grade 1, and you'll notice slight to moderate abnormal laxity in addition to some tenderness with palpation, varus stress tests, and a lot of different functional movements. And then grade 3 is a complete tear of the LCL. You'll notice significant varus instability with this presentation. Healing of LCL injuries can be unreliable. Typically, grade 1 and grade 2 injuries can heal with conservative management. Grade 3 has been shown to have superior outcomes with surgical intervention. Most grade 1 and 2s will return to prior level of activity within 6 weeks, and remember, that's just with conservative management. So it's a good prognosis for the lower grades. Grade 3, there isn't much research available to us, but it has been shown to have superior outcomes with surgical intervention. You're probably getting sick of this slide by now, but I think it's important to remind ourselves every time when we have a patient coming in to see us, we need to ask ourselves if this patient is appropriate for physical therapy or not. Differential diagnosis for LCL tears would be different ligament tears or strains such as the ACL, PCL, or MCL. Meniscal involvement, remember the LCL doesn't have a direct attachment to the meniscus, however we still can see meniscal involvement with an LCL tear, especially if there was trauma associated with it. IT band syndrome, the LCL is near the distal IT band, so ruling that out as well, which falls under the patellofemoral pain syndrome umbrella, is important. And then the popliteus strain, really uncommon, but it's going to be associated with that posterior lateral corner. And then a proximal calf strain. These are all different diagnoses that we need to have in the back of our mind, and as we develop our hypothesis list, some things that maybe should be popping up if we're suspecting an LCL injury. Clinical presentation of LCL injuries. Typically for an acute presentation, the patient will describe a dull pain with point tenderness. You might notice some bruising or ecchymosis and swelling. Perception of side-to-side instability at near full extension. That varus instability is how they'll describe it. Difficulty walking on uneven ground, both instability and walking. May see varus motion during the early gait phases. Less common, it would be paresthesia or foot drop. However, the peroneal nerve injury is reported with about 1/3 of LCL injuries. The peroneal nerve runs very near to the LCL over the fibular head, so it's also a differential diagnosis we should have on the list and consider during our examination. We'll go through the same observation process that we've done with all other knee presentations, looking at posture, assessing the gait pattern, and looking for any significant asymmetries with that. Here's a list of several physical impairments you can expect to notice during the objective exam. You may not see all of them, you may only see a few of them, but it should give you an idea of some things to look for during that exam. The picture on the right shows how you should have your patient sit when you're trying to palpate the LCL. You can also try to palpate it just in a normal seated position. I prefer to do it in hook lying, but some people highly recommend putting their knee in this position where you cross the distal tibia over the other leg, because it is supposed to expose the LCL more for you to be able to palpate it. You'll perform the varus stress test to assess the LCL stability. You'll do it both at 0 degrees and 30 degrees. If you notice increased varus excursion or increased pain, that would be considered a positive test. The dial test is another special test you may consider performing on your patients where you're suspecting an LCL injury. It's performed by comparing the amount of external rotation in each knee while the patient is in a prone position at 30 degrees of knee flexion and then 90 degrees of knee flexion. An increase in external rotation of greater than 10 degrees with the knee flexed to 30 compared to 90 is indicative of a posterior lateral corner injury. There's a few other special tests that you can consider performing for LCL and posterior lateral corner injuries. However, we're primarily just going to focus on these two. In fact, even with the dial test, I don't perform that too regularly on my patients because a lot of people have varying degrees of external and internal rotation, even in the normal asymptomatic population. So if you perform these on your classmates, I think you'll notice that each classmate doesn't have perfect symmetry during these tests. LCL non-surgical management should be the primary management strategy for grade 1 and grade 2 tears. Grade 3, it may be appropriate as well, depending on the level of instability. However, remember, the study from 2015 showed there were superior outcomes with surgical treatment. It demonstrated greater knee range of motion and greater pain reduction. There is no best evidence available for us to guide our physical therapy management. In fact, when you look at the different protocols online and the minimal research that is available to us, it seems like they're all saying different things. Some say that we should immobilize the knee early on. Some say we should immobilize at 0 degrees, some say immobilize at 30 degrees, and other things show that we should be mobilizing early. So we don't have enough evidence out there to guide our decision making in that. I think instead we should look at the patient's impairments and treat them accordingly. On the next slide, we're going to look at a case study of a patient who suffered an LCL injury, and we can look at the protocol that they followed. So here's a case study from 2018, an isolated LCL injury. It was a grade 3 injury. The protocol that they followed was 2 weeks non-weight bearing with the knee locked in extension. Progressive range of motion, weeks 2 to 8, and the brace was removed at 8 weeks. Sagittal plane exercises such as knee extension and hamstring curls were introduced at 8 weeks and progressed from there. And then by 4 months, the patient was able to return to multi-directional activities, and soon after that, returned to sport. If it's not just an LCL injury, but also a PLC injury, the patient is more likely to have a non-weight bearing protocol, and the patient will probably be in a knee immobilizer for 6 weeks. Typically, these patients will progress a little slower through rehab, but the goals remain the same of restoring range of motion, strength, and controlling pain and swelling early on. As the patient progresses through rehab, you're going to really allow irritability and the tissue healing principles to guide your decision-making process. If you have any questions, please let us know.